Okay, we'll make a start. Otherwise we'll be pushed for time later on. So bore da pawb, good morning and welcome to you all. Michelle, are you able to do the admitting? Yeah, great, thank you. So today we've got two talks. One, you're going to be fed up with my voice by the end of the morning because you're going to hear me cheering and I'm going to be presenting. But first of all, we're going to have Manon. But before we start, if everybody, what we do is with the webinars, we do the half-hour presentation and then we've got up to 15 minutes, 10, 15 minutes for questions and answers. So at that point, you can put your microphones on if you're asking a question, please introduce yourself. But in the meantime, can you make sure that your microphones are off, please? So if you just click up on the top right and mute your microphones, that would be great. Thank you. And the other thing to just ask is if you have got your microphone on, to make sure that your phone is on silent. So the first talk will start at about 10:15. And then what we do is after the presentation and the question and answers, we do a short Mentimeter. And then the second talk, because it's online and some people only come to one talk and not the other, we will hold it. If there is a gap, we'll have a short break and then start again at 11. Is everyone okay? I think we're going up. We've got 27 in now. Okay, so first of all, it's Manon, Croeso Manon. Manon is developing advanced clinical skills, including complex assessments, decision-making and coordinating care for patients with acute and chronic conditions. Manon is employed by Betsi Cadwaladr University Health Board as Trainee Advanced Nurse Practitioner, and she plays an active role in the team's pilot projects, which focus on enhanced care pathways for respiratory patients and those with heart failure. And today she's going to demonstrate or tell us all about a project that they're running on Ynys Môn or Anglesey called MEC, and how it's bridging the gap between acute and community services, ensuring seamless and patient-centred care. And I know it's had a lot of accolades, so we're really interested to find out more about it.
Yeah, so I'm just going to start on this video, just a little video about the team and what we do.
Signal that patients, staff and communities across Wales are still being let down, and it's so disheartening to all the hard-working, committed staff across the board. We are failing the 700,000 patients under our care. Long delays in ED, ambulance waiting times, GP appointments, cancelled operations.
The emergency departments at the moment are under immense pressure, and it's simply not sustainable for our workforce to carry on.
Pressure isn't sustainable. We spend hours outside the emergency department when we should be ready for the next emergency call. Things must change.
And corridor care isn't just a logistic failure, it's a moral, clinical crisis, and it's becoming the norm.
Manon is a small, tight-knit team rooted on Anglesey, yet it's quietly doing what entire health boards struggle to achieve. We are supported by a vast network of teams such as district nurses, occupational therapists, physiotherapists, home carers, palliative care teams and GPs.
In Wales, the number of people aged 65 years and over is projected to increase by 19.6% between 2022 and 2032, reaching a whopping 806,000. This will increase demand further. Older people are more likely to live with chronic conditions and multiple health issues, increasing the demand on GPs, hospitals and the social care sector.
We intervene early, often within hours, to stabilise patients at home, preventing unnecessary hospital admissions. We take referrals from GPs, the Welsh Ambulance Services, the Community Cardiology Team, residential and nursing homes, and Ysbyty Gwynedd Specialist Services.
As a member of Community Cardiology, I can't express how valuable the MEC team are supporting our service. When we see patients and we detect and diagnose heart failure, we're able to give the MEC team and refer these patients on from This means that the patient isn't admitted to hospital, the treatment at home.
My name's Martin, I'm a advanced paramedic practitioner working with the Health Ambulance Service. I've had the pleasure of working with the MEC team, spending time on placements as part of my advanced paramedic training, seeing firsthand the care that they provide to patients at home, enabling them to have care in the comforts of their own home, avoiding hospital admissions.
We can initiate multidisciplinary teams, which enables same-day assessments and tailored care plans.
We are supported by the COTI team in Ysbyty Gwynedd with weekly board rounds. We also work closely with Dr Simon Hill and the Frailty Hub in Holyhead. Advanced and future care planning is embedded, aligning care with patient wishes and reducing crisis-driven admissions.
We deliver timely, dignified, person-centred care that keeps people out of hospital and connected to their communities.
Since Rhys joined the MEC team 18 months ago, he has significantly reshaped its dynamics and performance, using his acute advanced experience within the community. By introducing a fresh approach, Rhys has increased the number of patients reviewed by the MEC team each month from 10 to 50. He has also dramatically reduced the average length of stay for the patients under the MEC team, from 20 days to just 4 days. This improvement has enabled MEC to manage a higher patient volume, easing the burden on the GPs and streamlining care delivery across the service.
The MEC service is an invaluable resource to us in the community in Anglesey. We regularly refer patients whose needs are complex, or if admission to hospital is just not in the best interest for the patient. As GPs, we are truly grateful to be able to work as a team with the MEC, and the patients and their families are truly thankful for this service.
MEC facilitates timely assessments, diagnostic testing with rapid results and access to urgent imaging through COTI consultants, while providing a high quality care at significantly lower cost than an inpatient admission. We have several initiatives currently ongoing. A trial in collaboration with the Sleep Ventilation Clinic is currently running, targeting patients who are frequently admitted with exacerbation of COPD. This pilot started in January 2025. Our very first patient was admitted 7 times during 2024, which totaled 117 stays. Our second patient had 9 admissions during that year, totaling 108 stays. Since the patients have been admitted to the MEC COPD pilot, they have had no acute admissions.
I became involved with this team because I suffer with COPD and I had a flare-up and the doctors wanted me to go into hospital, but MEC came and they rescued me. They got me ready to go on holiday, and even now, if I need them, all I've got to do is pick up the phone. They really are a wonderful asset to the NHS.
My name's Carrie-Anne Solow. I live in Kenmys Bay and I've got severe kyphoscoliosis. I've had it since the age of 2 and it impacts my heart and my lungs and my general mobility. And I first met the MEC team back in January. I left quite a desperate message really on the answer machine at the hospital because I was having one of my usual chest infections, but I really couldn't clear my lungs. I was choking, I was suffocating. And to be honest with you, I didn't want to get out of bed. I'm not like that, I'm a very happy-go-lucky person. Within 24 hours, the MEC team, who I've never heard of, turned up at my door. There's 3 lovely people and they changed my life. They come and check on me regularly. I don't remember the last time I went to a hospital, so I'm not around germs. And my infections have dramatically decreased. I'm back to working full time. My life's great and my mental state's a lot better. And I feel like there is hope for the future and I'm going to be here for a long time.
But there are clear paths forward if leaders are bold enough to take them. MEC's success on Anglesey shows that community can deliver high quality care outside the hospital setting. With its small, strong community ties and devolved powers, Wales is perfectly positioned to pilot bold reforms. If successful, it could become blueprint for a reimagined NHS across the UK.
Culture and compassion go hand in hand, shaping a healthcare environment where kindness, respect and person-centred care are at the heart of everything we do. This culture is designed to help staff feel valued, leading to improved well-being, greater engagement and higher quality patient care. But we must also recognise the reality. Our staff are worn out. Many are emotionally and physically exhausted, and the goodwill that once held our service together is fading.
That is the video that we played for our health board back in October, just to highlight the community can deliver acute high quality care to rural Wales. So I'll just carry on with this presentation. We are the only hospital at home service in North Wales. I think there's a virtual hospital home down in South Wales, but we are one of the only modules like this in Wales at the moment. So our team is very small. We have one advanced paramedic, Rhys advanced A&P, myself a trainee A&P, and then we have 3 healthcare support workers and an admin support worker, and they're part-time. So this team first started back in 2012, and it's only in the last few years, thanks to Rhys, this gentleman here, that he has pushed what was already an amazing team even further. He's brought his acute experience from acute medicine. He had 25 years of acute medicine experience, and he's brought it to the community. So our referral criteria includes anybody of the age of 18 with a chronic comorbidity or disability. They must be a resident of Ynys Môn, meaning they have to be registered with a GP on Anglesey. The patient consents or the family consents, and the patient has made a judgment that they don't want any GP out of hours, ambulance or acute admission, and that the GPs have deemed that being at home is the most appropriate care for the patient. We do have exclusion criteria where, the family or the support workers aren't able to support the MEC team. There's a strong indication of hospital admission, trauma, fractures, surgical conditions. The environment isn't safe for lone workers, or there's already a place in a care pathway in place, so there's no need for a hospital at home. So type of conditions that we manage, so we'll manage complex acute exacerbations of heart failure, COPD, MS, Parkinson's, CKD. We also treat new AF. We also treat fast AF with infection. We'll deal with TIAs, Ps, DVTs where the patient's refused hospital admission. We deal with AKI, so dehydration, electrolyte imbalances. We'll deal with severe infections that need close monitoring, non-injury falls or people who are frequent fallers, people that are off their legs because of infection. We can investigate, diagnose and treat. People who are off their legs with reduced mobility, and we can implement DNA CPRs and end-of-life care where needed. So this is all provided. We have a COTI consultant that supports us, and we do a weekly ward round, and she's also at the end of the phone whenever we need her. We carry point of care blood tests, so ISTATs, so we can have renal function and HB blood tests there and then with the patient. We can get lab results within 2 hours. We have access to rapid X-ray, CTs, MRI through our COTI consultant. We have a stock of ambulatory ECGs that we can put on a patient, and we can get the results back in less than a week. And we have urgent access to our social services, as well as district nurses, occupational therapists and physios. So our team isn't able to do anything without everybody else. So we need the support of district nurses, the GPs, equipment in stores, everybody. We can't do our job without everybody else. So the challenges we have is the fact that the ageing population is increasing. There's hospital pressures with beds, and our patients that we tend to see have chronic diseases. So them going into hospital, they have a higher mortality risk than anybody else. So there's clear evidence that hospital home has its place. If I just put, there's a clear financial impact to the acute compared to what we can do. This is one of our ladies.
How lucky are we living in Anglesey with the wonderful service of the MEC team? I first became aware of this service in 2022 when they were looking after my husband, and I cannot speak highly enough of them. Now in 2025, it is my turn to need help, and thank goodness for this brilliant service, keeping me out of hospital, taking up a bed, and enabling me to have all the necessary tests at home. They are an essential tool in our community and need to be encouraged and supported all the way. They have my heartfelt thanks for being there for me, and I certainly will support them in any way that I can, promoting the work they are doing in the community.
So the respiratory pilot started in January 2025. So she just came in and saw that there was a clear difference between acute and community and a gap between the two settings communicating. So the aim of the project was to reduce or prevent further admissions. And we were able to detect patients that were coming into the hospital frequently that the respiratory team deemed didn't need to be there, either they had an exacerbation which was non-effective, and having MEC involved perhaps could stop them having multiple admissions. So we've now done a full 12 months of the pilot, and we've done 153 admission avoidances in that 12 months. And we now have 47 patients on our caseload. And what we do is we manage their conditions and we provide them the empowerment to take on their care rather than phoning 999 or being admitted every time. So from this, we then did a collaboration with the cardiology team. And one of the aspects of this is that we look at remote monitoring in heart failure patients. So Hannah Jones, that you saw on the video, is a senior cardiac imaging specialist for the West community here. And she's doing an exciting innovation with monitoring heart failure remotely. So she's able to early detect decompensation, which is imperative for managing of heart failure in patients to achieve optimum quality of life. So the device is with Medtronic, and these cardiac devices are implants for direct therapeutic benefit to achieve resynchronizing of the contracting of the heart muscle. But what it also does, it collects data which allows Hannah and her team to monitor any decompensation early. And this data is collected daily. So they have a little device in their home, and that's able to upload the data from the Medtronic device and then to their database. So what it does, it gives them a low, moderate or high risk of patients who could be decompensating, and they're able to contact that patient there and then, do a triage over the phone. Any concerns, they then are able to forward to us. And this started back in September, and we've managed for 5 of these patients just from this particular pilot with the Medtronic. But from the heart failure patients from September, we've managed to stop 42 admissions. So here's the figures from 2025. So we received 620 referrals in total for MEC. That's including everybody, not just the COPD or heart failure patients. We managed 563 admission avoidances, and the average length of stay was 5.5 days. So our team's future is to promote acute, high quality care for the community. We can do an awful lot more in the community than what people think. So we want to reduce hospital admissions, chronic conditions managed in the community, enabling the patient to feel empowered with their own health and well-being, and try and alleviate that bed pressure. We are only a small team on Ynys Môn, and we've managed to do an awful lot in this 12 months. What we're trying to promote is, if we can do this with such a small team just on Anglesey, imagine the possibilities that we could do if this was adapted in the rest of Wales, in very rural Wales. Sorry, I went through that very fast. Anyone question? Anybody has questions?
Manon. I think Anthony has a question there.
Hi, Manon. Anthony, nice to meet you. Thank you for an excellent presentation on what you're doing. I just wanted to introduce myself really. I'm Anthony, I'm a GP and I'm the hospital home lead for Cadwaladr. So we're trying to do very similar things across rural West Wales that you're doing. We're based in 3 hubs across West Wales and have 3 separate virtual wards. Many similar themes to you. Well, I'm very impressed with what you're doing with heart failure and your respiratory patients. So probably worth us touching base with me and the other leads and all that. So thank you.
Diolch.
I think we also have a comment in the chat from Bianca. Is it similar thing in Cadwaladr? Wanted to get in touch, Manon. My question actually is, you said you presented to Betsi, and I always find it a bit of a mystery when we've got proven cases of integrated working or different ways of delivering services, and they're proven to be effective and over the longer term has a big cost saving to health boards. Why these aren't adopted broadly and widely, and the spread and scale model. So I was just interested to find out how did your presentation go to the board, and is it going to be adopted across Betsi? And the same for you, I suppose, Anthony, and however, if these are working in some places, can we not roll them out?
Yeah, so we had a very positive outcome from going to the health board. Again, finance is a big thing, but our thing was the fact that we've done this without extra financial support. They've got a similar theme on West, Central and East, where they have AMPs attached to district nurses that do with chronic, more than complex chronic diseases such as COPD and things. So our plan really was to try and maybe shift them slightly to do a more of an acute, similar to what we do, and maybe combine. So it's not even asking for more financial support, it's just changing the structure slightly. And maybe because the big plan is to have more in the community, is maybe transferring some money from acute just slightly to fund more district nursing to support these teams, to be able to do the weekends, the evening services that we don't cover, but we can implement the treatment if they can just follow it on. So it's not a big cost, it's just trying to keep championing what we can do.
Okay, great. I can see Nova's put a question for you as well in the chat book. Nova, do you want to speak, or shall I just read it out?
Oh no, that's fine. Thank you, Anna. My question was more about the referral. I wasn't sure how people got into the service, particularly with the sort of Welsh ambulance service, where they might sort of drop people off and go. Like, how does that kind of link with the Welsh ambulance service, I think, is probably the question there.
Yeah, so we have trainee paramedics at the moment, so we're trying to educate WAST more about us. So the first responders on the island are aware of MEC, so they're able to call us. They have our work mobile numbers. The only thing is we only work 9 to 5, Monday to Friday. If they think, yeah, possibly they don't need admission, they'll contact GP out of hours and say, I need this in place, but I'll need MEC then the following day or on the Monday. So we've got a really good working team with WAST. And because we're a small area, they're aware of us. So WAST will contact us directly, or they'll go through GP out of hours for the GP then to contact us on Monday morning.
Yeah, great, thank you.
The rest of the referrals can come from GP, the CRTs. If the patient's been known to us before, they can contact us directly as well.
Yeah, I got that bit from the video. It was just thinking about how when someone goes to somebody's house, like like Welsh ambulance, how do they get the person into the sort of system? Because I can see when they're in it, it works well for them. It was more about how different people accessed it. So thank you very much.
Yeah.
Anthony, you've got your hand. Yep.
Only to say in Hywel and other areas in South Wales, the ambulance service either sit with us in our hubs or will phone in. So we've got hotline access from the ambulance service, and we take direct referrals from crews on scene. We also sometimes take referrals before ambulances even get there, so we can see the ambulance stack, and we'll go to calls before the ambulance service to see if we can keep people at home as an alternative to admission. So Manon, I think that might be an area of development where you can actually see the stack yourselves and manage those patients. So.
Yeah. Great, thank you.
Anybody got any more questions, observations? Bianca, I'd be quite interested. Are you talking about the same service that Anthony's referring to from our lab?
Yeah, I'm part of the same team,
okay,
so it's the
yeah,
same.
Were there any more questions? No, I was just going to ask you what your next steps are then. You've done the presentation, it was favourable. Have you got, what are the next steps in terms of spread?
We've just finished a full 12 months of the respiratory pilot, so I'm just trying to put all those figures together now and write a research on there, because we've got a full month, and from that we're looking more into advanced care plans. Which we do work with Dr. Simon Hill, but he's looking to retire. And I do think for the team, it would work well if we can go and assess these patients and make an advanced care plan so their wishes to remain home is done. They've got a solid documentation then that WAST could refer to, GP out of hours, anybody.
Okay, brilliant. Anything else on the floor? No. Lovely. Diolch yn fawr, Manon. Thank you very much for your time, and keep up the good work, and look forward to hearing the results of your 12-month respiratory pilot, and perhaps you could present that at our conference in November. That would be quite interesting to see what the outcome of that is when you've done the data crunching.
Yeah, great. Thank you.
Yeah. Great. Well, this is when we have the break now, because we don't start the next talk until 11, because some people are only joining on for the one talk, like I said. So I'll just put everything on pause this end, and if you could come back at 11 a.m. and I'll be telling you about the Macmillan project we've done on the rural cancer patient experience, and hopefully have a discussion around that. Diolch. Okay, we'll make a start. Just a bit of housekeeping, just as a recap. If you've got your mics on, can you put your mics off? And then I'll give you the presentation, and if you can save your questions, either feel free to drop them in the chat as they come about, because if you're like me, you'll forget them. So drop them in the chat or put your hand up and we can come to them at the end. So for those of you who don't know, I'm Anna Prytherch. I'm head of...
Thank you. That's great stuff. That's good hours.
Right. Somebody want to put a microphone off. I'm head of Rural Health and Care Wales, and I'm going to just give a very short background to what Rural Health and Care Wales is, because I don't want to presume everybody knows what we do here. So we were set up, Rural Health and Care Wales was set up back in 2016, and it came about as a result of a study that was commissioned by the Welsh Government looking into the problems of Mid Wales, which was going through a period of unrest, similar to what is happening now, I think, with concerns raised about the delivery of healthcare services. So he commissioned a report. Professor Marcus Longley and a group of other people wrote a healthcare study for Mid Wales that became pivotal in setting up not just Rural Health and Care Wales, but also the Mid Wales Joint Committee for Health and Care, where the three chief execs of the health boards and the local authorities sit, and a number of other stakeholders. In terms of Rural Health and Care Wales, you can see that we have a broad stakeholder group as well. So I report to our stakeholder group and to the joint committee. So we've got the three health boards and local authorities, 5 universities, 3 research, innovation and improvement hubs, llais, and then primary care, GP, patient and public representatives. So it's quite a broad group to have as your management group, because you get a great input of diverse knowledge, experience and priorities. So see the dark area in the middle of there, some of the dots have now changed slightly in that we've got the integrated care centres as opposed to community hospitals in Cardigan and Aberaeron, and a few of the others are having changes in service delivery, including Towins going through a consultation at the moment, but it just demonstrates the region that we cover. So it's now a sparsely populated area of Wales, yet it covers the biggest geographical footprint with a very low density of people living there. So the vision that we were set by the Welsh Government and our stakeholders was to become a world-leading organisation in rural health and social care research, training, recruitment and best practice. And to do that, we do a lot of research into health inequalities facing people who live in rural areas, and then looking at ways to address these, but also looking at innovative ways of delivering health and care services to those who live rurally. And I'm not sure how many of you that are online now do live rurally, but we have good, the bad and the ugly, I've called it. So on average, people do tend to live longer in rural areas. We have higher happiness factors, lower birth mortality, but we do have a downside as well, in that the young male suicide rate for our region is higher than the national averages. We have access to services, obviously, is more problematic, and we have more complex health needs, etc. So the background to us doing this project came from one of the concerns. Obviously, cancer is the most common cause of death and premature death in Wales, and it accounts for around 25% of all deaths. And there is a stat there, if you look to the right in the Cancer in Wales infographic, I've just put a clip of it there, but they do assume that, well, not assume, but they predict that 4 out of 10 deaths are preventable. So that's another 25%. 40%, sorry, 40% of all deaths due to cancer are preventable. And they've put that down to smoking, of being overweight, obesity, poor diet, alcohol, too much sun and UV light, and lack of exercise. But those are generic to everybody. They're not specific to rural. But then more specifically to rural areas, and why we're particularly interested in doing that is that we have a particularly aging population. The expectation is that 1 in 2 people are going to be diagnosed with cancer during their lifetime. And with general trends that people are living longer with more complex health needs, this is exacerbated in rural areas because we have more of an acute inverted triangle, which is like that one. We have a lot of the young populations migrating out of rural areas to more urban areas for career pathways and to travel, etc. So we have a more acute in terms of health and care service provision, and also in terms of the people who live here. Access to health and care services is often a barrier to early diagnosis, treatment and care. So compounding all these issues and other impacting factors, we submitted an application in conjunction with Macmillan. We were actually approached by Macmillan, who we'd met and who knew the work that we were doing and our interest in rural. And we were encouraged to submit an application to look at that rural cancer patient experience. And that was back in 2022, which seems such a long time ago now, but in reality, those 4 years have flown. We put in an application and the project commenced in 2023. We did have a few months hiatus due to staff changes in 2024, but the project is now due to be completed in January 2026. In this presentation, I'm going to reference lots of sources of information, but I haven't cited everything, otherwise the slides would become cumbersome. So if there's anything that I cite in this presentation that you're interested in finding more about, my contact details are at the end, and so you can just contact me and I'll send you the source if you like. So this was the project, and our research question was, what differences, if any, do people living in rural areas encounter before, during and after a cancer diagnosis compared to their urban counterparts? If you recall, I said we're really looking at that rural-urban inequalities. So there is evidence already to show that rural residents are 5% less likely to survive cancer than their urban counterparts. They incur greater travel times for screening, diagnosis and treatment. They're more likely to be diagnosed through emergency presentation than routine screening or early presentation at GPs. They are less likely to undergo radiotherapy, and that is often through choice. People have turned down, and during this project, I've spoken to a lot of people who have decided that they don't want to go to travel, to the cost, to the time implications, etc., and the stress of travelling further afield to get that radiotherapy. And many experience more psychological unmet needs than urban counterparts. So we did the study to gain a better understanding of the perceived inequalities for rural people and to explore different ways in which care and support can be provided to people with cancer living in rural areas. And to do that, we looked to identify best practice, not only that was happening through that we could identify in evidence through literature, but also in networking and exploring existing services that are going on, not just in the UK, but overseas as well, and in Wales in particular. We considered the experience of professionals delivering cancer support services in urban and rural areas, and we concluded, or we're at the point of concluding, with a comprehensive set of recommendations and an action plan for improving the rural cancer patient experience in Wales. I should say that we're still at the final writing up stage. So this is a presentation of early findings, and the final report is yet to go through the screening internally to our stakeholders and partners before it will be a final published document, hopefully in April. So if anybody's interested in seeing the final document, if you can just drop me an email. Like I said, my contact details are at the end. We'll make sure that you're down on the mailing for that. Now my computer has frozen. There we go. So the project itself started 2023. It's to complete this year. It consisted of 3 stages, I would say. The first was a literature review that focused specifically on Wales to look at what evidence we already have, because this was a research project, in the literature. And then we extended that to include international scoping. So we were looking at those models of best practice. We also had to do the grey literature, because in any kind of delivery of current services, we need to be fully au fait with any strategy or policy documents that would impact the delivery of services. As part of the process, we held a number of focus group discussions with patients, their families, and with healthcare professionals who are delivering services to people with cancer. And we've also done a number of case studies which are focused on informal discussions with individuals, primarily those who have had cancer, but also those who are delivering support to people with cancer in rural areas. We've engaged with a lot of organisations that are involved with cancer and individuals who have an interest, be they volunteers or support deliverers. And we've done a number of public engagement and dissemination events like today. So that is trying to raise awareness of the findings of what we found, trying to engage with you as well. So I'll be asking you all to contribute your thoughts and feedback on the findings that we've had, and share experiences at the end of my presentation, which will be really invaluable to us and to the report. We've presented the findings from the work at conferences in the form of papers and academic posters, and that's been from the early onset when we were just outlining what we were going to do to try as an engagement tool, through to the early findings of the literature, both from the Wales and the international, and the early case study thematic analysis. We've done webinars, this being one of them, and we've been involved with a lot of consultations and workshops involved with the delivery of cancer services, particularly in the Mid Wales region, but more broadly across Wales. And we are involved, as you'll see later when I talk about the policy side, in national UK-wide activities. So I'll just start with the Wales Literature Review. This was work that Becky did early on in the research project. Those of you who've done a literature review would be fully aware of the process. So you select terms that you believe are relevant to what you're trying to find, and they are run through databases, and then you come up with a list of publications, peer-reviewed articles, etc., that are relevant to those search terms. So the databases that were searched for the Wales Literature Review were TripPro, Medline, and we used the National Library of Wales. We're very fortunate to be based in Aberystwyth and have access to that on our doorstep, literally. And we were using the search terms Wales, cancer and inequalities, and any synonyms attached to those. The resultant search came up with 34 papers, which isn't a large number, as you can imagine, but it was quite a tight search proposal. We scrutinised the abstracts and conclusions and selected papers that met set criteria. And obviously there's a lot of aspects, and we'll come to that later when I talk about identified themes, that were common to rural and urban, but we were trying to focus specifically at the rural, through the rural lens. So we looked at those that had a urban-rural differentiation focus, and we're comparing the two within Wales. We looked at those that had a particular Mid Wales focus as well, because that would be particularly relevant to the work that we were trying to do in Mid Wales. And that narrowed the 34 papers down to 10. And then from those, we also did additional searches ourselves in a more informal, just online, Google, etc. So iterative and grey literature for the more current documents that were pertinent to the work, and came up with 2. So in total, there were 12 documents that were scrutinised for this element of the work. And out of these 12 documents, there were 4 emerging themes. So the first one identified the urban and rural mortality factors. So this, you know, I think from the onset you saw that I mentioned there were 5% increase in mortality in rural versus urban, but this is affected by contextual factors, population composition. We've talked about the aging population in rural areas, and other methodological and data aspects. So there was contextualized, it had to be contextualized as to why that was. But there did appear to be what Ebeling and et al. In 2002, I have put in a reference there. I think that was one Becky put in, referred to as a mortality crossover. And that was primarily relating to the elderly rural residents, which we've already referred to. The second theme that was identified was prescribing and referral variation across rural places, rural versus urban. So it did appear that there was a bit of a postcode lottery in prescribing chemotherapy and other treatments, and it depended a lot on capacity and geographical determinants such as spirituality were impacted by policy. There was a weak correlation between primary care practices in affluent urban areas being more likely to refer for cancer genetic services. And I think that focused very much around Velindre down in Cardiff. So the urban centres down there obviously had easier access to the more advanced genetic services than we would up here. And thus the referral processes and pathways were utilised more often. Transport and travel, that's a common theme in all the projects and research that we do. It's a huge barrier to accessing not just health and care services, but for socialisation and mobility for people living rurally. So one of the findings there, the literature has been quoted, so people are receptive to a localisation of service delivery through chemotherapy and education buses, and equity of access to tertiary services such as the Heath in Cardiff or Morrison in Swansea require further investigation regarding acceptability. And then the fourth thematic output was palliative care. So specialist palliative care facilities can be distant to rural populations, with many patients wishing their wish was to die at home. And 40% of a surveyed population of bereaved carers felt they needed more nursing help. So we're very reliant on unpaid carers in rural areas, more so than more urban areas. And they often felt that they weren't receiving enough support themselves to provide adequate palliative care to their family member. And bereavement support as well was also identified as an unmet need. Key, I suppose, discussion points that came from the Wales literature findings. The geographical and spatial analysis may imply demographic and economic homogeneity, so that there is an inequality within rural and urban. There is a limit to existing research relative to the terms selected for the search. We have to put that in as a proviso. It's a limitation because your findings are only as good as the search terms you put in. But if we'd have broadened them, we wouldn't have been answering the specific research question that we wanted to. Rurality as a determinant may not always translate to health disadvantage, but combined with contextual and population factors, which does include that aging population, can result in negative outcomes and experiences for rural populations. And then the finding from this is there's a gap in the research. So it just proved the need to undertake this work to kind of look to evidence the need and make a case for more to be done for people who are living in rural areas who have cancer. The next part then was doing the international literature review. And this was a bit more in depth because we started off, we used the similar search phrases, and we looked at rural versus urban cancer search terms, and it covered the resulting findings that we had. We did it through the librarian at Hywel. We're very lucky to have access to a qualified librarian who can do the searches on the databases for us. It covered 18 countries, and the emergent themes to date were reflective of those that we had already found in Wales. but they had more of a focus on screening, the stage of presentation, decision-making, and psychological and psychosocial impact of having a cancer diagnosis. So you can see there from the MBase and Medline, their search databases that we do literature searches on, that 2,407 articles came out as a result, and we scanned those for the abstracts and conclusions, looking for relevance and weighted them, reducing them down to 244. We also did a search on the PsycInfo database with 314 articles output, and then from those we narrowed that down to 31. So between them we had 275. The iterative and grey literature sourcing, I've put to be confirmed in number. We have done about 25, but they're ongoing as they, I don't want to put a finite number there until the report has been concluded. So the international initial scoping reveals, as you can see from the previous slide, most of the themes were the same as those identified in Wales. However, these were 4 kind of different areas that we felt deserved mentioning. So the definition of rurality, for a start, was a bit of a complicated things to navigate, because different countries and different identified rurality differently to how we would in Wales. So that was always a sticking point. What is rural and what isn't? So we have to get over that hurdle before you start anything. So rurality definitions can be broad and interchanged with distance. So, and also coastal is a big key player now. In England, for example, the coastal is often included as rural and coastal, whereas we don't define it as broadly as that in Wales as yet, but I think it's coming. There is a focus on different cancer types, and the different types show different mortality trends, and that's become apparent across Mid Wales as well, and also in terms of health pathways, that we have different levels of access to services, I would say, and different outcomes for different cancers. There is no one-size-fits-all approach, and individual and community participation can be key to understanding rural experiences and needs. And then documented solutions include outreach services, screening programs, cultural appropriation, and telemedicine. And we're going to come on to those at the end. This was a bit of a mind mapping type exercise when we input common thematic titles from the research that we did, and it's just showing you how they all link together and how we try to combine them and define them and make something comprehensive, or come to a comprehensive conclusion from the literature. So they're just some of the titles that we worked with them. So at the core you can see decision making, quality of life, and unmet needs were central to all of the other aspects. And then we simplified those into 4 key areas: barriers to access, barriers to screening, barriers to ongoing support, etc. Supportive care needs, the types of intervention, and then cancer mortality and survivorship. Those were the 4 kind of thematic groups that the international literature could be broken down into. The third element then of the work that we did focused on the case studies, and I'm kind of combining this with the focus groups as well that we did. So a lot of work was undertaken with groups of people, just speaking to them collectively, but we also did individual, they weren't even interviews, they were speaking to individuals to try and just capture their experiences of what it was like to either have a cancer diagnosis and then the treatment side, or how it was to care for somebody with cancer or somebody who has had cancer and how they found it. So it was for people who have had cancer, that's difficult to say, their carers, unpaid carers, formal carers, their family, friends, colleagues, healthcare professionals. And this is the part we're still writing up because we're still capturing a few. And if anybody that is here today wishes to share any of their own personal experiences, we'd be more than welcome to capture that as well, because the richer it is, the better. But key findings and issues are apparent and that have come to the fore, starting with screening and early diagnosis. Particularly, I think we're going to talk about the 4th point there with the agricultural sector. in primary care, it was a common comment from GPs that if a farmer turned up at your surgery with a cancer, it was more likely to be a stage 4 than a stage 1, and that people often push these things to the back of their mind for various reasons, from, you know, psychological or psychosocial, or even, well, it could be because of work pressures, it could be because people don't want to know, it could be that, you know, if you admit it, that, you know, then you have to face it. Or there could be a multitude of reasons why there is the late presentation, and I see that as a huge area that needs further investigation, because we all assume different reasons for late presentation, but we don't actually know. So that's another piece of research that is potential for the future. And so screening and early diagnosis, access to screening, education about screening, information on screening, all that comes within that topic. And of course, early screening leads to early diagnosis. Accessibility, we've already mentioned the transport issues. We did another piece of work on GPs and access to primary care across Mid Wales, working with the SAIL dataset team. I don't know if Roderick here, I saw his name on the list earlier. But that was really comprehensive in evidencing the distance travelled by people living in rural Mid Wales to their GPs, and how accessibility is a problem. So even though we can all assume it, we can all talk about it, it's nice to see it actually evidenced and quantified in an academic publication. So there is a report on that if anybody's interested. And the need for outreach and education became totally apparent, and not just outreach and education. When you come to the recommendation, we talk more in depth about it, but also that supportive element. So these were the thematic analysis from the focus groups and case studies that we did. There was a lot referred to from a community perspective, and the environment the people were working in, access to GPs and primary care as the first point of contact, jobs and lifestyle, some of which prohibited access, acute oncology services and access to those. They often only being available in the large tertiary centres that are sited in more urban places across Wales. The time then that is linked to travel, work, etc., time away from family, the stress, the cost, transport and travel, like we've said, and even trains. You know, a lot of people from the Powys area, for example, go over to Shrewsbury and Telford, and the train connections are much better than if you tried to get a bus, and I'll talk about that more in a minute. And the financial impact. And the financial impact we've kind of identified and recognised, however, we haven't gone in depth in it because it's a financial impact that affects everybody. And it isn't specific to rural, although there are more financial pressures potentially from that agricultural sector, but they operate as self-employed businesses. And there's animal husbandry implications within that as well. I know Linda's on because I said hello earlier, and I'm going to mention your project in a minute as well. So I was just going to give you a verbal account, and I haven't written this up because we're going through the consent issues. Although I have had consent to relate this to you verbally. It was one patient that I spoke to who was resident in North Powys, and they were using a North Powys GP, was their GP, and I don't want to name it, but you can all work it out. And they identified she was over 70, so she was no longer able or no longer included in the screening program for breast cancer, but however she did have a health background and identified that what she felt was a lump in her breast. So she presented herself to a GP. She had the test, yes, she had breast cancer, and she was offered treatment, and she was sent for radiation treatment down to Prince Philip down in Llanelli. And this proved to be impossible because it was 5 days for 20-minute treatment. This lady had lost her husband, she lived alone, she had a dog, and she did not drive. So she was very reliant on public services. To get from her home to the hospital was a 4-hour one-way journey. And she would need to do that every day for 5 days for a 20-minute treatment. And she also had the issue of having a dog at home with nobody else to care for the animals, and she did not want to stay the night which you would have to have had paid for a hotel anyway, but she did not want to stay there. She knew she had to come back on a daily basis. Luckily, this person was aware that she could potentially access services in Shrewsbury. So because she went back to the GP and asked to have a referral to Shrewsbury, which was an hour and a half on the train as opposed to the 4 hours, and it meant a much easier, shorter day. She went every day for 5 days, got the treatment. But there, I came across lots of cases whereby people have been offered treatments which have proved to be too obtrusive, and people have turned it down, and that's a real big concern. And at the end, I'm going to ask if anybody else wants to share any case stories that they know about, because I'm sure that's just one of many that we can all relate to. The final part I'm going to just mention is, even though this research was very much focused on the patient experience, we also, obviously, any policy or strategies in place would have implications to that individual, whoever they may be and wherever they may reside. And I've just flagged that some of the policies that are relevant currently in Wales, although there are a multitude of them, as I'm sure a lot of you are aware. But and I just wanted to highlight the key themes from the Cancer Improvement Plan that is current up until this year. And one is prevention, and this links directly to the recommendations that we've got at the end. So that's why I wanted to highlight it. So prevention, early diagnosis, equitable access to care. These are all things that should be in place. Patient-centred care, innovation and research should be prioritised, collaboration and integration, and then infrastructure improvements and improved outcomes. So these are key areas that the Welsh Government has identified needs a real focus. And from everything that I've relayed to you so far, and I'm sure from your own personal experiences, you'll see that there's a lot of work to be done. The other thing that I've put up here is a rapid diagnostic programme that has implications on the recommendations, and then the quality statement for cancer, which again is a really interesting one for people to read. So the cancer research strategy, and this backs the need for doing research like this, is quite interesting. I've flagged a few up there, but I'm just looking at the time, so I'll probably just skip that slide and you can read it in your own time, because I wanted to talk about a paper that we were involved with. As part of doing this work for Macmillan, we were contacted by some researchers in Lincoln who are working on policy review across the 4 nations of the UK, and they asked us to be involved from the Welsh perspective, so we did. So just a bit of background there. The UK's diverse geography means people live in rural and coastal areas where cancer outcomes are often poorer than in urban settings. Devolution means that the 4 nations of the UK have distinct approaches to cancer care, and each of them have produced recent cancer strategies with England. This was produced last year before the England strategy is out, but it is out now. And so this study just looked at the cancer policy documents across all of the nations to see if any consideration was given to the particularly difficult or the particular challenges of rural and coastal areas. And the conclusion was that despite sizable rural and coastal populations facing specific health challenges across the UK, national cancer policies, except for Northern Ireland, gave minimal guidance for delivering cancer care that were tailored to these communities. Other UK nations should consider adopting more rural-centric approaches like Northern Ireland, and that paper has been used to try and flag some action with the Welsh Government and the governments across the UK. So 55 cancer policies were reviewed, 7 in Wales, and I can provide those if anybody's interested. Northern Ireland is worth looking at their cancer policy if anybody's interested in policy, because they do a rural needs impact assessment, which we would really advocate for within Wales. And it says UK cancer policy lacks specific focus on the needs of rural and coastal communities. Oh, that should say unified. Sorry, there's a typo there. UK-wide approaches to rural and cancer care could improve the outcomes. This was a published paper. If you wanted to look it up, the reference is there. And as a result of that, we're working with Lurch in Lincoln to set up a place-based action for cancer equity network. And if anybody's interested, there is an event on the 25th of February. I thought I'd flag up quickly. and you'd be more than welcome to attend. And even if you can't attend, they are going to be doing a survey, and if you're interested in the rural cancer patient experience, then please let me know and you can be sent a link to the survey. So coming to the concluding slides, early findings and recommendations. Outreach services are crucial in rural parts of Wales, not just for education and information, for screening advice and access, how they can access screening, and then all aspects of support. And there is, we've talked about the strong communities we have in Wales. There is an element of stigma sometimes attached to people admitting they've got cancer. And we need to encourage conversations. We need to make people, like, for mental health at the moment, there's been a huge push for people to be more open about discussing mental health. A similar thing needs to be undertaken for cancer. People don't like to say they've got cancer for various reasons. Transport and access to services, obviously linked to the need for outreach. That's another huge issue, and it's another project that we're actually working on. Michelle, I don't know if she must be here somewhere. She's doing a project at the moment for impact, just scoping transport, public and community transport, because that is a huge barrier in rural Mid Wales. We need more patient-centred solutions to be prioritised, even though in all the documents it says everything should be patient-centred. When it comes to the crux, there are still times when the patient's best interest is not taken into consideration. My big drive is the need for rapid diagnostic clinics or centres, be they mobile, to be used across Mid Wales, and to have mobile clinics or treatment units for the people of Mid Wales. Rather than expecting our patients to travel, can we not instigate some form of outreach for them? The technology is there. I haven't mentioned telehealth and the possibility to deliver support services electronically, but that is implicit throughout. We need more consistency in terms of the health pathways, particularly at a primary care level. Reports of discrepancies in the advice provided, different health pathways being used, and I think it would be great to have a regional cancer health pathways. I'm not fully au fait with the practicalities of that, but that is something that I've advocated and that I'm raising and starting discussions on. Supportive networks and sharing best practice. There's great work being done across Mid Wales. It's not all doom and gloom. And I've mentioned the POWIS Improving the Cancer Journey, supported by Macmillan. That's a great asset for POWIS, but why don't we have that throughout Mid Wales? Why is it just specific to POWIS? I know we have our own things in Hywel Dda and Betsi, but that is a great example of best practice in action that we could regionally do with adopting. The other one is the Farming Community Network that Linda shares. She might want to say more about in a minute. And then, we were just really grateful to Macmillan for supporting this work and the work that they're doing across the region, across the UK. We need policy change and adoption of a rural lens. Whenever policies are formed, and they do have implications in delivery at a very local level, very rarely are they seen through a rural lens. It's always, from what I can see, urban-centric. We need to change that, and we need to make moves to try and get the need for policy change in front of the right people. And we need more work on prevention and holistically addressing the social determinants of health. Like I said at the onset, 40% of cancers are preventable. If only we could work collectively with all our partners and look at more prevention, and in fact as individuals to consider how we can prevent even getting cancer in the first place. I'm going to stop sharing now because I won't be able to see if anybody's got any questions, and like the other speaker, I'm afraid I went over. So does anybody have any questions or experiences they'd like to share? Oh, Rodri's put in the chat box a link to the report if anybody's interested on the GP's distance travel. Linda, you've got your hand up.
Yes, thanks, Anna. That was a fantastic presentation and so much information. And I'm looking really forward to seeing the finalised report as well, which I think you mentioned was due in April, I think, was it? Yeah,
we're just completing it now, but it has to go through the stakeholders and then it'll be published in April,
Yeah, the research has been comprehensive, and I was quite struck as well is, I suppose you mentioned as well the low level of articles available for you to assess in the first place in your methodology.
In Wales, yeah.
Yes, in Wales. And yeah, that strikes a chord with what we've been experiencing with our project, the Rural Communities Cancer Project. Is there was hardly no literature we could evaluate and research in the first place to see what was needed to change for the better the late diagnosis for farming people. So yes, it all resonates with us, Anna, and I think it's going to be so useful for our project, the Rural Communities Cancer Project, moving forward, because we're grateful as well for the extension from Macmillan for another year and a half to our project. Brilliant. When we can do so much more. Just to add that as well, we've just taken out at all the markets, the auctioneering markets in Wales, these massive posters you see there regarding raising awareness for cancer as well, to try and get people to the doctors earlier for an early diagnosis. There will be one of those big massive posters in all the marts in Wales, and they're already up. I've had confirmation of them and I've seen the documentation. It's simple. I can share with you again, Anna, if you'd like to see them, to try and get people to go visit their GP. But one of the huge barriers is, as you mentioned, is trying to get a GP appointment in the first place. Yeah. And yeah, that is difficult, especially for farming people, because I don't know where all the GP surgeries do this, but quite a lot of them have a callback facility when you phone first thing in the morning. Farming people can't stay in their house all morning, all day waiting for a call back. And because of poor mobile reception as well, they can't take their phone out to them to the fields whatsoever. So yeah, that doesn't help in the first place. Sorry, I don't want to hog all the time here, Anna, but I wanted to mention as well, because yeah, the great things happening in Northern Ireland. And what we're doing at the moment as well, because our Rural Communities Cancer Project is across the 4 devolved nations, we're piloting and working with vets in Northern Ireland at the moment, because what we've realised is, since COVID really, is, I don't know what the reason is behind this. Is it just a coincidence it's to do with COVID or not? Or the way the businesses have changed? Nobody goes down farm lanes anymore. Years ago, you had all kinds of reps and salesmen turning up on the farmyard, so a farmer would see somebody to chat with, etc. These days, nobody, apart maybe from, if you're a dairy farm, if you're driving a milk tanker, you'll go down the farmyard. Nobody else visits the farmyard anymore, apart from the vet. And usually farmers have a really good relationship with their vet. So our Northern Ireland project is working with vets to make them comfortable after having received the Macmillan training, to strike up a conversation with farmers, maybe after they've been TB testing or just a routine visit, saying, well, okay, your cows are looking great. How are you feeling? Is there anything bothering you, etc.?
Oh, that's great.
So, yeah, so hopefully, once the pilot in Northern Ireland concludes, and I've already spoken to some vets in Wales to see if we could get them on board in Wales to have this conversation when they go down to the farmyard as well. So we'll see what's happening with that. Also, we're at the moment, I don't think you were at our Senate reception, Anna, were you? No.
I couldn't make it. No, I did add with him, but I couldn't make it, sorry.
Oh, yeah, that's okay. Yeah, I can see Dawn was there.
Yeah.
We started filming, making short films as well of actually farming people, speaking about their journey and what they found difficult. And as you've mentioned as well, it's the travelling times. We're collecting reflective summaries as well, and things like 5-6 hours return journeys daily. It's just so crushing for people when they've got livestock to look after and they don't necessarily have anybody who can give them a lift, and no public transport to speak of at all. So all the barriers you mentioned, there is so much work to be done. In some ways, it's quite depressing seeing what needs to be done, if you see what I mean. But hopefully, by working together, we can make a difference. So
the first step is recognising it, isn't it, that there is a problem, and then we have to move to address it. And I think it's fantastic. For those who don't know, Linda works for the Farming Community Network that's again funded by Macmillan, focus on the agricultural sector, delivering cancer support. But what I often think in rural areas, it's great the work you're doing, don't get me wrong, but wouldn't it be great if that kind of support and the level of awareness that you're raising could be rolled out generally to everybody who lives rurally? Not everybody's a farmer, and yet we all live, you know, a lot of people live in remote areas of Wales with a similar.
Yes, definitely. Yes, and we are targeting rural communities as well. Is because quite often at shows, agricultural shows and events, it's not just farming people who attend, it's the local community as well. For example, the Royal Welsh Show, it's a huge visitor attraction. It's not just farming people, it's a day out for everybody. And I think last year at the Royal Welsh Show, we had fantastic engagement on our stand there from people who weren't necessarily farming, but were from a rural community. I think Rachel, my colleague, is on the call as well. Rachel, is there anything you want to add? There's probably loads more, but I don't want to hog the whole meeting.
Is that Rachel Ackers just put a comment?
Yes.
Is that, she's asked about the Wales cancer strategy. There will be a new one because obviously it's still 2026. It has to be updated, but I think there's some voting coming up, isn't there? So that might be putting things on a bit of a stall. I don't know, but I'm not aware when it'll be released, but there will be another one out soon. Thank you. Thank you, Linda. And thank you for your comments. And we'll have to catch up again for another chat before, and you put some input into the draft report as well before it's finalised. George, I can see you've got your hand up. Diolch.
Yeah, I'm not employed by the NHS, so these are my personal views. I'm not surprised with your lady's experience in North Powys about the long journey times. And I listened to Linda say virtually the same thing about quite a number of people who've had this problem. It's happened to me twice, where I've been given appointments in Prince Philip, and when I've questioned it, I've been given one appointment in both, and another appointment now is in town in Aberystwyth. So I've been able to avoid that movement. But I'm afraid my personal suspicion is I was heavily involved with the stroke unit in Bromlais. And I think that it's part of a deliberate but unwritten policy to move everything down to the M4 corridor and make the public awareness of Prince Philip as being our local hospital for these things, so that we become accustomed to being in the north of Ceredigion, Powys, and the south of Gwynedd. We become accustomed to being transported down, being sent appointments for Prince Philip. So we begin to think that's the norm, whereas it's a complete inconvenience for people, and people have declined treatment on the basis that they can't possibly get there because of other commitments.
Well, yes, I agree with you in terms of what you're saying about treatments. I don't think so much. I mean, Bromlais is still very much at the core of hospital services in Mid Wales. I can't speak for the Health Board entirely. I know Nia's here. She knows on more of the strategy side than me. But I don't think they're trying to move us down to Llanelli. But there we go. Thank you for your comments. And would you be interested in being a case study, George, if I could have a quick chat with you?
Yes, of course.
Okay, I'll contact you afterwards. Thank you.
Okay,
Dawn, you've got your hand up.
Hi. I just want to say thank you for the excellent work that's being done by all three projects, actually, that we're funding in. But this, particularly related to this, what's hit me as I've been listening to the talks earlier from the advanced nurse practitioner as well, is there's room for collaboration, thinking beyond the cancer lens, really, because you mentioned around acute oncology, and that's been found to be a theme. And I know in lots of areas, there's lots of issues around acute oncology where patients present side effects of chemotherapy with a temperature, etc. And they sometimes have to sit in A&E as well as travel miles. And it just struck me that if we collaborate a bit more with all these projects, where they're developing these outreach teams and they've got telemedicine, etc., there is potential to link it to the early, I'm not saying they can do cancer treatments, but at least prevent people going to hospital and early detection of side effects, etc.
Yeah, collaboration is always good, isn't it? And I think it's only by keep coming to these events and talking about what you're doing that you can pick up on the possibilities of sharing best practice, as I call it, but and joining together. It's all about integration, isn't it? Thank you, Dawn. And and thank you to Macmillan, because I've worked with Dawn, has been my reporting person in doing this work. And without the funding, we wouldn't have been able to do it. So that's been fantastic. And Dawn, you're a nurse, aren't you, by trade? So you've got an added interest.
I am a bit long, not cancer, mainly in maternity actually, but but as I say, I think there's the collaboration as well, and Macmillan strategy, which is focusing more out in the community. We need to make use of and keep our ears peeled really around future funding.
Yeah, well, all the strategic direction is meant to be going to community-based care now, isn't it? That's why it's great to hear about what's going on in Ynys and we do need to take our services to community settings, and hence some of the recommendations made, about that outreach element. And Nia's put in the chat about the low uptake and health screening. Yes, we've identified that, and that's why one of the recommendations is we need to do more work about raising awareness of screening, and we've been working with the Public Health Wales screening team to try and raise that information, but there's a lot to be done. There's a lot more to be done. Great. Any comments from anybody else, or anything somebody wants to bring up? No. Thank you all for your time, and like I said, please contact me if anybody wants to input into the cancer report, or if you have any suggestions for future webinars, or if you want to yourself present on a project or some research. Ooh, that's interesting, Dawn. As a project or a research that you would like to share with everybody else, and use the webinar as a platform to do so. Diolch yn fawr. Thank you very much. Ta-ra.